Hello everyone, myself Keerthiga, M.Sc Nursing, Nursing Tutor, E.S College of Nursing, Visale. Now we move on to the condition of emphysema. Introductions. Emphysema is a long-term condition that causes a shortness of breath. Over time the condition damages the thin wall of the air sac in the lungs is called alveoli. In healthy lungs, the elastic sacs help the air leave when you breathe out. But when the air sacs are damaged in emphysema, it's hard to move air out of your lungs. This doesn't leave the room for fresh, oxygen-rich air to enter your lungs. These sacs stretch and fill with air when you breathe in. Now we move on to the definition. A disorder affecting the alveoli, tiny air sacs of the lungs. The transfer of oxygen and carbon dioxide in the lungs take place in the wall of the alveoli. In emphysema, the alveoli become abnormally inflated, damaging the walls and making it harder to breathe. Emphysema is causes dilation of air spaces by destruction of alveolar wall, leading to collapse of alveoli during expiration. Move on to causes and risk factor. Emphysema is developed due to smoking, cigarette, inhaling toxin or other irritant, and alpha-1 antitrypsin deficiency, a genetic defect which can cause emphysema and early age in non-smokers. This factor is increase a chance of developing a emphysema. Smoking cigarette is a long-term exposure of smoking is one of the causes. Second-hand or passive smoke exposure. Family members with emphysema. Exposure to pollutant at work. For example, you have to working in chemical factory and using a fumes or dust inhaling, there is most exposure in pollutant. Exposure to indoor and outdoor pollutions. Frequent lower respiratory infections. History of frequent lung infections. Age 50 years or older. Connective tissue disorders. Next, HIV infections. Types of emphysema: centriacinar, pan-acinar, paraseptal emphysema. Centriacinar emphysema. Centriacinar emphysema is a most common type of pulmonary emphysema. It's mainly localized to the proximal respiratory bronchioles with focal destruction and predominantly found in the upper lung zones. The surrounding lung parenchyma is usually normal with untouched distal alveolar duct and sacs. Paracinar emphysema. Pan-acinar emphysema involves all portion of the acinus and secondary pulmonary lobe more or less uniformly. It predominates in the lower lobes and is a form of emphysema associated with alpha-1 antitrypsin deficiency. Paraseptal emphysema. Paraseptal emphysema is characteristically bounded by pleural surface or interlobular septa. The anterior and posterior portion of the upper lobes and the posterior portion of the lower lobes are most often affected. This form of emphysema may be accompanied by bullae. Now we move on to the pathophysiology. Smoking is one of the causes and risk factor. Is a decreased antiprotease is alpha-1 antitrypsin deficiency and another one increased protease, elastase from neutrophils and macrophages. It may lead to both elastic damage. It may lead to emphysema. Clinical manifestations. So, early symptoms include emphysema, coughing in the morning, coughing up clear sputum, mucus from deep in the lungs, wheezing, shortness of breath with activity, decreased exercise tolerance, increased shortness of breath, rapid breathing, choking sensations when lying flat, bluish lips and complexions, that is cyanosis, due to the lack of oxygen in the blood, fatigue, increase in chest size, barrel chest, coughing up thick or bloody mucus, swelling in the ankles and legs. Next, loss of appetite and weight, breathing through pursed lip, desire to lean forward to improve your breathing, enlargement of the right chamber of the heart, heart failure. Next, we move on to the diagnostic evaluations, health history and physical examination, spirometry and other pulmonary function test, chest x-ray and or CT of the chest, atrial blood gas analysis, complete blood count, pulse oximetry, sputum examinations, pulmonary ventilation, perfusion scans, testing for alpha 1 antitrypsin deficiency. Next, we move on to the medical management. We have to give adequate oxygen to those patients. Oxygen therapy is needed. Next, bronchodilator medications, steroids, antibiotics, breathing techniques, postural drainage, chest percussion. On surgical management, lung reduction surgery, bullectomy, lung transplantations. On nursing management for emphysema, it's include medication, pulmonary rehabilitations, smoking cessation, nutritional support. On medications, bronchodilators help to relax airways and breathing. Inhaled steroids, it will reduce our inflammation and help with shortness of breath. Aerosol sprays reduce the inflammation and help with shortness of breath. Antibiotics, so treat bacterial infections. Pulmonary rehabilitations are beneficial for patients with COPD who are medically stable and symptomatic, can be delivered in inpatient, outpatient or community-based settings. Smoking cessations. Stopping smoking is the best way to prevent COPD from getting worse. It's never too late to stop smoking. Next, we move on to the nutritional support. A whole food approach to nutrient supplementation, for example, increasing intake of fruits and vegetables. As the benefit of increasing intake of multiple nutrients including vitamin C, vitamin E, carotenoids, flavonoids, shows a more promise in respiratory disease in terms of reducing risk of COPD. Next, move on to the complications. A respiratory insufficiency or failure and pneumonia and pneumothorax, chronic atelectasis, cor pulmonale, intestinal emphysema, recurrent respiratory tract infections, respiratory acidosis, hypoxia and coma. Thank you.